Clinical shock is a critical condition where the body's tissues are deprived of adequate blood flow. This means essential nutrients and oxygen cannot reach organs, and waste products build up, leading to dysfunction. Shock is not just a drop in blood pressure, it's a complex, life-threatening process that can rapidly progress if not recognized and treated early. Understanding shock is vital for anyone in healthcare, as timely intervention can mean the difference between recovery and irreversible organ damage. In this scene, we'll explore the basics of shock and why it's so important to identify and manage it promptly. Shock doesn't stay static, it evolves. In its early stages, the body tries to compensate, but as time passes without treatment, the cardiovascular system itself begins to fail. This progression makes shock increasingly difficult to reverse. Early identification and elimination of the underlying cause can restore cellular function and prevent permanent damage. However, delays in treatment result in irreversible shock, multi-organ failure, and ultimately death. Recognizing the signs early and acting fast is the cornerstone of effective shock management. Shock is classified into 4 main categories based on the underlying hemodynamic disturbance. These are hypovolemic, cardiogenic, septic, and neurogenic shock. Each type has distinct causes and clinical features, but all share the common thread of inadequate tissue perfusion. Understanding these categories helps clinicians tailor their management strategies to the patient's specific needs. Let's briefly introduce each type before diving deeper into their details. Hypovolemic shock is the most common type, especially in trauma cases. It results from a decrease in circulating blood volume, either due to acute blood loss or massive fluid shifts. Hemorrhagic shock occurs when blood is lost rapidly, such as from injury. Non-hemorrhagic shock can result from burns, pancreatitis, or severe dehydration. The body's response includes vasoconstriction and increased heart activity, but if the underlying cause isn't corrected, these compensatory mechanisms fail, leading to worsening hypovolemia and organ damage. When blood volume drops, arterial pressure falls, triggering powerful sympathetic reflexes. The body tries to compensate by constricting blood vessels, increasing heart rate, and releasing hormones like angiotensin and vasopressin. If these mechanisms fail, blood flow slows, tissues become ischemic, acid builds up, and capillaries become leaky. Fluid moves into tissues, worsening hypovolemia and leading to irreversible multi-organ necrosis. This vicious cycle highlights the urgency of rapid intervention. The clinical presentation of hypovolemic shock varies with the degree of blood loss. Mild cases show postural hypotension, cold sensation, tachycardia, and concentrated urine. Moderate cases present with thirst, supine hypotension, and reduced urine output. Severe cases are marked by agitation, confusion, profound hypotension, persistent tachycardia, and rapid deep breathing. Importantly, serum hematocrit and hemoglobin are not reliable indicators of acute blood loss. The severity of hypotension correlates strongly with mortality risk. Cardiogenic shock arises from the heart's inability to pump blood effectively. This can be due to acute myocardial infarction, severe cardiomyopathy, or mechanical obstructions like ventricular septal defects or valvular regurgitation. The result is decreased cardiac output, elevated pulmonary capillary wedge pressure, increased peripheral vascular resistance, and low arterial pressure. These changes compromise tissue perfusion and can quickly lead to organ failure if not managed promptly. In cardiogenic shock, the hemodynamic profile is distinctive. Pulmonary capillary wedge pressure rises above 18 mm Hg. Peripheral vascular resistance increases, and cardiac output drops below 2 liters per minute per square meter. Arterial pressure falls below 60 mm Hg, These parameters are critical for diagnosis and guide management decisions. Monitoring these values helps clinicians assess the severity and response to therapy, ensuring targeted interventions for optimal outcomes. Septic shock is triggered by severe infection, often from gram-negative bacteria, fungi, viruses, or parasites. The body's response involves a cascade of inflammatory mediators, including TNF-alpha, interleukins, and prostaglandins. These cause profound vasodilation and hypovolemia, leading to acute circulatory failure. Diagnostic criteria include arterial hypotension, altered mental status, organ perfusion changes, and elevated blood lactate levels. The interplay of endotoxins and immune response often results in multi-organ failure. Diagnosing septic shock relies on key clinical and laboratory findings. Arterial hypotension is defined as systolic blood pressure below 90 mm Hg, or mean arterial pressure below 60 mm Hg. Patients often exhibit altered mental status, changes in organ perfusion, and elevated blood lactate levels above 2 MEq/L, indicating impaired cellular metabolism. These criteria help clinicians identify septic shock early and initiate aggressive management to prevent organ failure. Neurogenic shock occurs without blood loss, resulting from a loss of vasomotor tone. This causes massive venous dilation and expanded vascular capacity, leading to inadequate tissue perfusion. Vasovagal syncope, or emotional fainting, is a common example in clinical settings. Excitation of cardiac parasympathetic nerves and skeletal muscle vasodilator nerves reduces heart rate and arterial pressure, dropping cerebral blood flow. Recovery is rapid when the patient is placed supine. Early symptoms of neurogenic shock include pale or ashen skin, heavy perspiration, nausea, tachycardia, and warmth in the neck or face. As the condition progresses, late signs appear: cold hands and feet, hypotension, bradycardia, dizziness, visual disturbance, and loss of consciousness. Recognizing these signs is essential for prompt management and preventing complications. Effective shock management requires continuous monitoring. Key parameters include ECG, pulse oximetry, blood pressure, and heart rate. Tachypnea and worsening hypotension or tachycardia signal inadequate resuscitation. Urine output is measured continuously, with a target of over 40 milliliters/hour, indicating adequate renal perfusion. In moderate or severe cases, central venous pressure and pulmonary artery wedge pressure are monitored via Swan-Ganz catheter. Regular lab tests, including arterial blood gases, pH, electrolytes, and blood lactate, guide therapy and assess response. Shock management begins with positioning and warmth. The patient should be placed supine with legs raised to enhance venous return and cardiac index. Keeping the patient warm is crucial, as hypothermia worsens acid-base disorders and myocardial depression. All transfusion fluids must be warmed. Fluid resuscitation starts with crystalloids like normal saline or Ringer's lactate. Colloids or blood products are used for massive hemorrhage or when crystalloids are insufficient. Immediate life-threatening hemorrhage may require uncrossed type O-negative blood. Pharmacologic support is essential in shock management. Dopamine is the vasopressor of choice, preserving renal and mesenteric perfusion. It's diluted in normal saline or 5% dextrose at 5-10 micrograms per kilogram per minute. Norepinephrine can be added if hypotension persists at higher doses. Dobutamine is used in myocardial depression to increase cardiac output without altering arterial pressure, reducing systemic vascular resistance and improving tissue oxygen delivery. The goal is to maintain systolic blood pressure at 90-100 mm Hg, mean arterial pressure at 70-75 mm Hg, arterial oxygen saturation above 95%, and hematocrit above 30%.